Hello, everyone, and welcome back to WoundCasters by Wound Care Today, where we explore the gaps by exploring the truth. I'm your host, Felix Boecker, and today I'm excited to be here with two incredible guests. But before we begin, don't forget that you can reach out to us through our website at wct-us.com, where you can also find tons and tons of educational material all related to the world of chronic wound care. Today, my guests are Richard and Linda Benskin from the Benskin Research Group out of Texas, and I'm so excited to have this conversation with them. They've done some incredible stuff in the world of wound care. So welcome to WoundCasters, you two. So excited to have this conversation with you. How are you doing with this weather? Because it's freaking cold where I'm at.
It's not here just yet, but we're going to get your weather in a couple of days. We're kind of gearing up for it down here. It's not the usual thing in Central Texas.
Yeah, I know.
And thank you for having us.
Oh, absolutely. No, I was when Miranda made this introduction, I was really excited to have this conversation. I checked out some of the stuff that you had shared with me content-wise, and I think there's some really cool stuff. So let's get into it. So the Benskin Research Group, what is it? What do you do?
Well, our journey started in a somewhat unusual way. We spent 5 years in Ghana, West Africa, helping to operate and develop the staff at a small Christian clinic out in the true backwaters of northern Ghana. And at that time, prior to that, I'd been a fireman. She'd been a pediatric nurse, actually. But we were seeing all kinds of different situations, and we were kind of taken aback by the amount of wound care cases we would see. Turns out, doing a little bit of poking around, apparently 20% or so of the folks in a lot of those environments suffer from some sort of debilitating wound. Now, we were fortunate in that we were at a clinic that had a lot of donated materials, and we had quite a few modern wound care products, but the Ghanaian nurse that we were working with pointed out that stuff doesn't work here, which we were very dubious of. So Linda, being the intent clinician that's interested in the data, started going through it, and for the most part, he was correct. We had extremely dry weather in the dry season, extremely wet weather in the wet season. We were getting mixed fungal infections under things, and hydrogels turned to goo, and just all kinds of various problems with most of the wound care products.
The heat is just really hard on most wound care products.
We're talking about cold here.
That's
We'd
so
see 130 there sometimes.
Wow.
So anyway, we did come across one product, which she ended up, that was working really well there, that we were able to get more donations, and that evolved into her day job working for Ferris Manufacturing that makes Polymem. But we also realized that with our interest in developing world wound care, you're never going to maintain supply chains or supplies of that. So that kind of started our thinking on, there's got to be a better way. There's got to be some way that you can use locally available materials to get modern quality wound care. And that was a very long journey. It was like 25 years ago when we were working at that clinic, and only in 2021 did we actually finally do the RCT and develop our approach.
Wow. Yeah.
So
Linda.
Yeah. So I was looking at all of these donated wound supplies one at a time. My colleague Peter Bombandi would clean up a wound with the equivalent of Dakins, basically, and then give me a clean, not granulating wound, and I would try the next appropriate wound dressing on him. I was getting terrible results. The next dressing to try was Polymem, and when I used it on a patient, I got tremendously good results. So I started using only Polymem on everybody. We contacted the company. They generously donated stuff and even figured out how to get it to us. So that was great. But we were also teaching village health workers who were going out into the hinterlands throughout Ghana and even into Liberia and other countries. And obviously they weren't going to be able to get donated Polymem. And so it was very frustrating. And we realized how disempowering it is to teach someone how to do wound care using materials that they cannot obtain forever.
Sure.
And so we sort of developed a mindset that we need to come up with something sustainable. It needs to be entirely materials that are found in village markets. It needs to do all the things that we know that modern wound care knowledge teaches us that we need to do. So it needs to keep the moisture balance appropriate, not too wet, not too dry. It needs to promote autolytic debridement. It needs to keep the inflammation low. It needs to not adhere to the wound bed. It needs to not require any system of cleaning the different pieces of the dressing technique that you use, because you're going to be using this with people who are mostly doing self-care out in villages, and they don't even know that germs exist. So how are you going to tell them that those banana leaves or other leaves that you're telling them to use are just covered in microbes and they need to be cleaned? They're not going to do that because they don't know what a microbe is. And so it needs to be something that's good to go just the way they obtain it. And obviously that was a pretty high bar and a pretty big challenge. So we kind of set that aside. We came back from Ghana in 2004 and didn't do much with it until about 2009 when I quit my job.
And prior to our time in Ghana, West Africa, we'd been on numerous short-term medical mission events, clinics and so forth. And we'd seen people coming in with the latest, greatest stuff and spending a week somewhere. And our time in Ghana made it obvious to us that that was not a good approach, because even a lot of times people come in with good medications. You see someone with hypertension and you give them, 2 or 3 bottles of hypertension medicine, and then you leave and they're stuck. So the wound care has the same sort of problems. We wanted to find something that we could teach to the local caregivers and even the local wound patients, that they could take care of their own problems without relying on something that was going to run out or go bad in the heat and have all those kinds of problems.
Yeah. So,
go ahead. No, please. It's your story.
Okay. Yeah. So I had worked from 2005 or so until 2009 for the people that make Polymem, and I was really happy doing that. It's a great product, and I felt like I was making a difference in the world. But then someone challenged me with the question, what are you doing for village health workers now? And nothing. So that renewed our interest in this question about the dressings. So I quit my job, went to University of Texas Medical Branch in Galveston to get my PhD, because we knew that I would need credentials if we were going to teach village health workers in countries other than Ghana in order to get permission from the ministries of health. Richard, at that point, transitioned to being my technical advisor. And actually, he became the technical advisor for the entire group of PhD students. And we had quite a ride there. So I, with his help, basically got the fastest PhD in the history of nursing, probably. In 2012, we were already doing my dissertation research. And I worked with Dr. Laura Bolton. Some of your viewers may know who that is, who is my mentor, in trying to come up with a research study design. And originally, I had published a couple of literature reviews as part of my work for my PhD on what was available in terms of improvised dressings and improvised debridement techniques, that kind of thing. And there was virtually nothing in the literature on this topic, going all the way, with no date limits, no country limits, no language limits, anything. And I had a librarian who specialized in this area helping me, because I was at a good university, and those literature reviews were really just pretty sparse. Almost everything that was known about wound care in tropical developing countries came from dermatologists, and it was mostly just surveys and stuff. They would give a list of what things people did in what materials they used, but nothing about how they used them. So, I mean, So they used this particular leaf. Did they boil it and use the basically broth from it? Did they drink it? Did they apply it to the wound? We knew nothing. Yeah. And so Dr. Bolton said, you cannot do a study comparing your dressing to something else because you have no idea what usual practice is. And
Yeah.
so that was our dissertation research, which was a pretty I guess, ambitious dissertation research. My dissertation chair said the university would never allow anyone else to do this dissertation research study, but because you lived in Ghana for 5 years and you have connections there and you are in your 50s, we will let you do this.
So for the dissertation study, we went back to Ghana. We were there for about 3 months, getting our feet back on the ground and reconnecting with the clinic where we had worked, which was a great resource because they had connections with people all over Ghana that were able to help interpret from the local languages. So we traveled to 25 different villages scattered across the entire country, which has multiple ecosystems. You've got your coastal region, you've got a little north of that, so kind of a true tropical jungle region. And then up in the savannah, you've got the savannah's kind of the borderland to kind of getting into the Saharan climate to some degree. So there's lots of different, drastically different climates. You've got a little bit of mountainous area. It's not like the Rockies or anything, but where you've got altitude, you have a different set of issues. So we were able to visit with 3 different kinds of providers in these 25 different villages, making for 75 interviews that had to be coded. It's another long story there. But at any rate, the 3 provider types were a village healthcare worker, which we'd had a village healthcare training program while we'd lived there. So these were people with minimal
Western
medicine training. The one type was the traditionalist, which varied from an herbalist, some of whom had a little bit of Red Cross training somewhere down the line that tended to use leaves and potions in different various ways. But some of the traditionalists were what most Westerners would call, what the local people would call juju men. Westerners some people would call it witch doctor, which is not a very favorable term. But anyway, there were people we interviewed that were wound care included throwing chicken blood against the wall and all kinds of things that you wouldn't expect. And then the third provider type was just like a grandmother, a person in the village who people kind of went to if they had a problem. Sometimes it would be a midwife who also did other things. And of those 3 types, we got a broad spectrum of how people would respond to, what do we have, 5 or 7 different wound types?
7 different wound types.
7 different wound types that we presented, and we had a fairly unique interview format that we developed as well, which was we call it a story completion, because the local culture is very prone to
they're hospitable.
Yeah, the hospitality is very high in virtually all of the Ghanaian cultures. So there's a tendency to give the answer that they think you want to hear rather than the answer that is actually the answer. So we present them with a photograph of a wound case that we'd actually seen in the clinic when we'd lived there and give them a basic background. And then we'd begin asking just open-ended questions. Okay, this person comes in with this history, with this, say, burn wound. What would you do first? And what would you do then? What would you do then? We wouldn't ask, how would you clean the wound? Because that would make them think, oh, I'm supposed to clean the wound. And they'd be inclined to make up something about how they cleaned the wound, whether they did or not. So it was all very open-ended questions. So we got, hopefully, and we believe from numerous indicators, good information on what was actually the usual practice of these folks. And the interesting thing that we found, well, the process started, we'd go to the village chief and get permission to do the study in their village. And in the process of that, we would ask him who he would go to if he had a wound, or who he would send one of his friends to if he had a wound in that village.
Sometimes he had a wound, and he'd say, "I go to
sure."
Yeah.
So that gave us a lot of data to crunch through to come up with usual practice. And the most interesting thing that we found is in each village, for the most part, the most respected provider was attempting to do moist wound care, which we all know. Well, I guess there's some people surprisingly that don't still know it in the West, but that we know is the proper way to do wound care. but they were struggling to have a way to effectively do it in their environments.
Yeah, the wounds tended to dry out, and they were unhappy about that. And that was a universal thing that we saw across the better traditional healers and the village health workers, was the difficulty in keeping wounds moist enough. And so that confirmed for us what we believed, but some people didn't believe, which is that moist wound care is still effective even in that environment where you have such a high infection rate. Because some people were saying, oh, well, you're better having it drier because you don't want to promote germs in this moist, warm environment. And the answer is no, it doesn't matter. Your white blood cells still trump the bacteria.
Yeah.
And you have to do something that is, promoting what the body needs.
It might be worth noting also that, here chronic wounds are usually associated with some chronic disease process. There, frequently, the chronic wounds that you would see were just poorly managed, simple wounds, bug bites, minor trauma, that in that environment and with poor care would become chronic.
That was actually one of my questions was, what kind of wound categories do you see out in that environment? Are they mostly traumatic or burns, or do you see diabetic foot ulcers? Do you see venous leg ulcers, right? The stuff that we see here in this country so much, right?
Well, we saw a few diabetic foot ulcers, but sadly and honestly, the diabetics in that environment often don't make it to the point in their lives where those issues come up. And we saw actually our research study, which we need to get to before too long, was focused on sickle cell leg ulcers. And we didn't know much about them at that time. We saw at least one or two of those. We figured they were venous ulcers at the time, but now we realize that several of those cases were almost undoubtedly sickle cell leg ulcers.
Yeah, the most common wound there, especially among the children, is what we would call a tropical ulcer, which you used to see in the United States, but with better hygiene, you don't see it much anymore. And actually, soldiers in Vietnam had a terrible problem with tropical leg ulcers. And interestingly, the ones who came from the South didn't, because they had probably gotten those when they were a child and had developed some immunity to it. But the rest of the troops in Vietnam often suffered from terrible ulcers that were disabling. And so that was one of our 7 wound types. And then we also had, obviously, lower leg ulcers that would look like a venous ulcer, burns, various trauma kind of issues, and then cancer, oddly enough, which we did actually a pre-study that I hadn't mentioned. That was a qualitative study where I sent pictures by email, 30 different pictures by email to preachers who worked in remote areas and also had some village health worker training, and just asked them, which of these do you see most often? And I was really surprised that the cancer came up, but that makes sense, because if you have a chronic wound long enough that's not well treated, eventually it is likely to become cancerous, especially your burn scars also can get Marjolaine ulcers. And then the other one that was kind of surprising is osteomyelitis, which can, if it's not treated, will create a little recurring ulcer that comes and goes. Right. And that makes sense too, because you have a lot of malunions when you have fractures. So all of this, of course, is available. It's published in Wounds Journal, and so Wound Care Today, various places. So that's, if people want to learn more about that original study, it's available. Also, good posters on my ResearchGate. But anyway, so after we did the dissertation study and I graduated, then obviously the next question is, I'm not old enough to retire. I don't have any money. We spent everything getting my PhD. And so how do we support ourselves? Mm-hmm. And I thought I was going to become a university professor, but God being so wonderful, that didn't happen. And instead, the people I'd worked for before, Ferris, who makes Polymem, recognizing that I had a passion for this, said, how about if we offer you a hybrid job where you can work for us, but you can bank time to go ahead and do your village health worker stuff that you want to do, and periodically take a trip or whatever you need to do. And so that's basically the job that I still have today. I do plan to retire in November so that we can do this full time.
Yeah.
as volunteer work, but we are also going to be partly retired. At this point, we're in our late 60s.
Sure.
So we'll combine the two. But anyway, so that leads us into our randomized control trial.
Right. Exactly.
Yeah,
Yeah,
so
we definitely.
So from some of the background research that she did, we found some things they were doing in Japan with food grade plastic wrap, where they're doing a special process where they're perforating it and wrapping it. And we knew that wasn't going to work in the tropics because the heat is not going to, people are not going to tolerate a circumferential wrap. But we jumped off of that idea and kind of modified it in various ways. One of the biggest challenges, actually, I'm kind of shifting gears here. One of the biggest challenges was finding a site to do the study. We developed a
Really?
concept that we wanted to test out, but for it to be beneficial for the audience we're looking at, the patients needed to be living in a true tropical environment. But to do a robust RCT, which was also important to us, you needed to do it in a place where there were clinicians that were capable and willing and experienced in following a tight protocol. So there were some nurses that we met numerous places at some of the conferences that we go to that wanted to do the study in Malaysia, but we did a little looking around and we found out that virtually all the patients would be going home to their air-conditioned living room, and that was not going to be an applicable comparator to the patients that we're looking at. So eventually, after quite a bit of looking around and trying various places, Cambodia we looked at, and there were issues there, we ended up with Jamaica. And the University of West Indies Hospital and one of the communities in Kingston, Jamaica, was a good fit. The people live there. Most of the patients they see are in significant poverty, go home to a true tropical environment, but there are nurses and doctors that are highly trained there. So we landed there. We tried to do the study in 2020. COVID hit, and
Politics.
And there was also an election coming up that was somewhat dicey, and the people at the hospital that are working there said, you just need to go home and try again later. So we came back in 2021 and actually did the study. COVID was still hampering especially our ability to recruit participants. Also, something a lot of people don't know is that Jamaica is kind of almost ground zero for sickle cell leg ulcers, which is a really good test group because it's a very, very challenging wound type. A lot of the patients that we did end up seeing, I think the average was 7 or 8 years for the wound that was in the study. Some of them had wound for a couple of decades.
Wow.
Anyway, so
That's a long time.
So we settled on sickle cell leg ulcers for our wound type, and started the study down there at the hospital.
Yeah.
We worked with the director of plastic surgery there and several of the nurses and residents.
Yeah, Dr. Rajiv Paul needs a shout out there, and also Antoinette Barton Gooden, because had it not been, and Graham Crickendale too, had it not been for those Jamaicans working with us, there's no way we could have pulled off the study.
Yeah. And this is the study then that led to your product development, or that was part of your product development.
Correct. So, okay. Yes. Yeah, so what the product is, as we've hinted at several times before, is really just a technique. So it's a very careful way of using materials that are available in any village market or the dollar store. So the emphasis on how it's used, it has to be done very carefully. So there are 5 main steps to the process, and those steps need to be followed exactly. And one of the things that we learned during the study from teaching people how to do self-care is that people who aren't wound experts have no clue why they're doing each of these steps. And if you don't teach them why they're doing each step, they will make mistakes that you never even dreamed of. And they will substitute things that just won't work because they don't understand what's happening. So there's a partnership that takes place. There's an education that takes place. It's not an instantaneous thing. So this cannot spread through a short video on the internet. People need to actually do return demonstration in which you use analogies to explain why each step is like. So I'll go through the steps, and that'll help you your audience understand what I'm talking about.
Yeah,
So
please.
the first step is that you need to irrigate the wound. Um, if you can do an initial sharp debridement on the wound, that is really great. Unfortunately, because of the COVID restrictions, we couldn't do a lot of sharp debridement on our patients. And that's really complicated. That doesn't make sense, but it's true. And so we only had one of our 48 study participants that had sharp debridement done initially. And the rest of them, we had to rely on autolytic debridement completely to clean up a very initially slough-filled wound. Because the sickle cell leg ulcers are so challenging, even here in the United States, with the best, greatest techniques that you have available, most of them do not ever heal. So if we got any wound closure rather than the wound getting larger or stagnant, we felt like we had a success. We weren't looking for complete closure in only 12 weeks, which was we had a staggered start, staggered stop RCT. So we were just looking for improvement. We weren't looking for complete closure. Anyway, so the first thing we wanted to do is irrigate the wound. And Richard is an extremely innovative guy. And when we lived our 5 years in West Africa, that was extremely handy because he can pretty much fix anything with whatever is available. And he came up with the idea, we want an irrigation device, and nursing says that you need a certain number of PSI, and to get that, you should use an angiocath attached to a 5 ml syringe or whatever. Well, you're not going to get any of that stuff out there. So he found out that if you take a cast off 500 ml soda bottle, which are available on the side of the road pretty much anywhere in the world, and you rinse that out really well, and use a hot bicycle spoke or any cast off piece of wire that you've heated up, and you can poke a hole in the lid. You fill that with clean water, and you have a really good irrigation device that's just the right PSI.
And if you should happen to want to use normal saline, the bottle cap is just about the right amount of salt to make normal saline in the bottle.
Right.
Wow.
Anyway, so if the patient already had water that was clean enough to drink, if it's clean enough to drink, it's clean enough to use on a wound. Wound care is not a sterile process.
Right.
Telling people to boil things is a really big mistake because boiling consumes a lot of resources. It uses some of your clean water that is a precious resource. If you have to clean it, because it goes away in steam. It also you have to create a fire, and so a better solution is solar water disinfection, which there's a Swiss organization that has an entire website dedicated to solar water disinfection, and those same clear bottles. If you fill them with water that you filtered to where it's clean enough that you can see through it to like see large print type, and then you put it up on the roof in the tropical sun, because we're talking about helping people in the tropics, 6 hours of the tropical sun, the UV rays will kill everything, even HIV. So that's actually more effective than what you can get from boiling, which you have to boil a long time to kill spores. So we taught solar water disinfection to the few patients in Jamaica that had water that was from a iffy well or something like that. Everybody else had potable water. But in the tropical regions that this product is intended for, solar water disinfection is more important. And then, so we've got an irrigation device. So we taught them how to irrigate. They have to do it at an oblique angle because you want to push the germs out of the wound bed instead of pushing them down into the wound bed. You don't want to spray stuff back up into your face. And of course, that requires having, some absorbent towels and stuff like that around where the wound is to absorb that extra water.
And you want to continue irrigating until the stuff that's coming out is not cloudy anymore. It may be a little pink from the a little bit of blood in there, but you want to continue irrigating until it's no longer cloudy.
So that tells them what their goal is. And then the next step is that you need to protect the peri-wound, because we're going to be promoting autolytic debridement. You teach them what autolytic debridement is. It's basically God's way that he has provided your body with cleaning a wound. And I liken it to clearing the slab after a fire before you build a new house. And so you're going to end up with a clean wound bed that the new growth can form on. But for autolytic debridement to work well, you're going to need to have a moist but not overly wet wound bed. And you are going to then produce a large quantity of straw-colored fluid, and that fluid has proteolytic enzymes in it, so it's going to tend to want to digest the intact skin. So you need to protect that intact skin that surrounds the wound bed with something. And that something is whatever the local people use when their baby needs its bottom protected.
Okay, that's going to vary from location to location. And on the RCT, we used zinc oxide because it's widely available in Jamaica. In Ghana, where we lived before, it would have been shea butter, which grows there, and you can buy it in the market for practically nothing. So that's going to be dependent upon the location.
Right. A lot of people think Vaseline, but in the tropical environment, Vaseline's going to melt and isn't going to provide any protection. It'll just disappear. But zinc oxide paste is really cheap, and it's available pretty much worldwide. The zinc oxide paste that we got off of Amazon for the study was less than $1 a tube, and most people didn't use more than one tube for the whole 12 weeks. Sometimes they'd use a couple of tubes. So it's very inexpensive, and expense was a big thought. So they're going to, in advance, prepare the next step. So even though it's the third step, you do it before you even irrigate, and that is your plastic. So Richard mentioned earlier that the Japanese had used clear plastic food wrap.
Right.
Unfortunately, you don't buy food wrap out in the middle of nowhere, and it's relatively expensive. It's kind of cumbersome. But that same plastic is also found in other forms. So in India, they took that study, and they had been using banana leaves that they had autoclaved, and they switched to using sterile surgical wraps, plastic surgical drapes. And that worked really well for them. So we said, okay, well, why don't we use the thin plastic bags that are available everywhere? Now, the shopping bags, we had all kinds of bags, moisture vapor transmission rate tested. And so we had people from all over the world send us plastic bags, and we persuaded a company to test them for us after hours for free. And they found that pretty much every plastic bag that we had, even if they looked completely different, some were colored, some were clear, some were crinkly, some were softer. They all tended to have a very low moisture vapor transmission rate, but they were semi-permeable membranes. And that's what we were looking for.
Along with the little bags, like around here, we used to use them, the flip top sandwich bags. The bags that are very similar to those we found in Southeast Asia and the remote houses in Cambodia. They use them all over West Africa.
South America.
These are what people typically take their soup or their rice or even their drinking water out to the field for their day of work in. So you can buy them, you can buy a packet of 100 of them in a dirt-floored village market for practically nothing in most of the world. So with the plastic bags that they take their water or their soup in, ended up being the device that becomes the heart of this process.
All right. So your foundation is a clear plastic bag, and that's a surrogate for the saran wrap or the surgical drapes. And in Australia, they use that same plastic wrap as their first aid for burn wounds. And so emergency room had plastic wrap in the emergency room sitting there for over a year on the shelf, and they were wondering what all was growing on it. So they actually plated it and found that nothing grows on it. Germs hate it. It has no food for them. They don't like it. So it's an inherently clean product. And of course, and of course, the inside of the plastic bag, if you put a plastic bag in your pocket, then the inside of it is going to stay clean. And so that makes a really good way for a patient to have spare wound dressings in their pocket and not have to worry about them being dirty. They just need to use that inner surface that is completely clean. So that is, we bought those bags at the market, and they come in various sizes for various size wounds in Jamaica. And we were able to buy a bag of 100 bags for well under $1. So a very inexpensive system. So the way that you use it, though, rather than wrapping it, is you cut the plastic bag slightly larger than the wound, so it'll cover the peri wound as well, where your zinc oxide paste or shea butter is going to be. And you want it to be big enough that even you're going to conform it to the shape of the wound. So if you have a deep wound, it needs to be a bigger size so that even after you conform it to the shape of the wound, it still reaches the peri wound. Then the trick is, because of the autolytic debridement and that low moisture vapor transmission rate, you're going to need to cut slits in it for the extra fluid to have a way to escape.
Okay.
It was important that those are slits, not holes, because you only want it to kind of burp out the extra fluid. You don't want to have a wide open area where it's going to dry out.
Or adhere to whatever material's behind the plastic bag.
Right.
Yeah.
So this plastic is cut in advance before you even do your rinsing. You cut it first, then you do your rinsing. You cut slits in it. You have to be sure that at least one of those slits is in the dependent area of the wound, so that when the person is walking or swinging their arms, depending on where their wound is, the fluid will drain out of that hole rather than going over your peri wound area. And then if the person's going to elevate their leg, of course, it's going to have a slit on the other end of the wound. Yep. So you need to explain what the purpose of the slits are, so that the patient, when they make the slits, will make them in the correct place and will position them right. It's important that our peri wound cover is something that is completely non-toxic. And what they use for baby bottoms is going to be non-toxic, because a baby will have excoriated skin, and whatever they use isn't killing babies or isn't making erosions in the skin. So you know that that's a good choice for their peri wound thing. Then over top of your plastic, you put your plastic down after you do the peri wound. You have to dry the peri wound, because otherwise the peri wound barrier won't stick. You put down your plastic, you conform it gently to the wound bed with no air bubbles or any moisture, because what I would tell the patients is, if you've got a lake, the hunters that are your body's white blood cells aren't going to be able to find the bad things in there that are going to make your wound get infected. But if you have just a path, the hunter can easily win the battle.
Mm-hmm.
And on top of that, you're going to put an absorbent.
And that absorbent, once again, is going to be dependent on what is available in the location. You can use one of the easiest ways to do it is to ask what the women use for their menses. That's going to be some absorbent material that's around and available, and they have. In Ghana, when we were working there, we used a lot of bed sheet bandages. So simple cloths that can be washed and reused can be there. If cotton is available, you can do that. In some of the areas that we worked in Ghana, they would use, in lieu of cotton gauze, the plantain stalks. When a plantain is cut, they dry that material out, and it's an absorbent, fibrous material that they can use. But at any rate, you use anything that's absorbent, that's conformable, and you press it down against the plastic to, one, keep the plastic against the wound bed, and two, to absorb whatever exudate is coming through the slits that you've cut.
Sure.
Anyway, then you cover that with something that's going to hold it all together. So if the person can do compression, wonderful. If they can't, at least we can hold it together. That can be on a leg wound. It could just be a sock. You can cut the toe off a sock and put it up higher. If you need it up higher, you can use the sleeve of a long sleeve child's t-shirt. You can use children's tights that are very popular these days as a stretch thing to put over it. If you've got a clinician who's doing this process all the time, they can use those bedsheet bandages, which gives you a no stretch compression. But I wouldn't recommend teaching that to a lay person who has a temporary wound, because it's difficult to teach. And if you don't do it correctly, you'll get pressure injuries at the top and bottom of where the edge of that dressing system is.
Of course, if they're available, you can use stretch wraps, but again, they have to be used carefully.
Right. But a lot of those other materials would be more expensive. But what's available in villages is they go to used clothing markets all the time. And so used clothing is a really good source of something to use for both your absorbent and for your wrap or whatever you're going to use to hold it in place at the end. Anyway, and then this dressing is changed every day. So every day they take everything off. They wipe off their peri-wound protectant. They irrigate again, put new peri-wound protectant, new plastic wrap, new absorbent, new cover. Some of those things, if they use torn small pieces of cloth for their absorbent, those could actually be washed and hang out on the line for the UV rays to kill any germs. And the same thing with their outer wrap. Otherwise, they're going to be throwing all that away and replacing it. The plastic wrap, definitely they replace every day.
Gotcha.
And that's the
So,
entire process.
yeah, so I do want to be cognizant of all of our time here. So, but I have so many questions. Like, what are the outcomes that you've seen with this approach in the tropical
That's what I
climates?
was going to talk about next.
Right, and
But
and
yeah,
on top of that, is that something that we can do here in the United States as well, or is this really something that is more geared towards the tropical climates? But we have patients in limited resource environments here in the U.S. as well. So I can definitely see
absolutely.
how there may be a potential for using some of this here in the U.S.
Yes, we've actually had conversations with a number of clinicians that work in settings where they were very interested in this. We've gone to several of the conferences for the correctional care group for the prisons and jails who are tending to wounds where people are going to be back out. Some of these people on the streets or who are
Authority averse,
and teaching them self-care with this method is something that we found a lot of interest in. There are also a number of nurses that we found that work with the unhoused, with the people who are living on the street, and going out and doing clinics from time to time, and they've had a great deal of interest in that. So,
like we said, everything that is available at the dollar store, rather than the plastic bags that we were talking about, the flip top sandwich bags are available at Target. They're available at dollar stores, and they're very inexpensive.
Or you can use the food grade wrap, but it tends to be clingy and a little bit more trouble to work with, but it will work.
Yeah. Anyhow, so the results of our trial, we had far above our expectations, the results of our clinical trial. The first thing is it truly was a non-adherent dressing. So we alleviated the biggest problem that our sickle cell leg ulcer patients had, which is the damage that was done at every dressing change, because every dressing they had tried stuck. And so we had a truly non-adherent dressing that dramatically decreased their pain. Just the occlusion also dramatically decreased their pain. So compared to usual practice, so we had a 3-arm study. So the available technology dressing, then the positive control was polymem, because it's the only dressing that's got good evidence in the tropics. The negative control was fluffed saline-soaked gauze that was a wet-to-wet dressing. That's not what they used. It was superior to what they used, but we just weren't willing to use anything that was going to stick.
It's close to usual practice in the areas we were willing to go. Usual practice just was kind of bad.
Usual practice was wet to dry, and we just weren't willing to do that. Or a thin ointment, which a non-anti-inflammatory ointment, which also stuck and turned into glue. So we had dramatically better healing with the available technology dressing, working towards closure, than we had with the saline soaked gauze. Not as good as polymem, but it was good enough that you wouldn't be embarrassed to recommend it. And we believe that once I retire, I intend to put out the challenge to people here in America and say, can your favorite dressing outperform a plastic bag? Because personally, I think that the available technology dressing keeps wounds a lot moister than most modern wound dressing choices. And most of the time we are keeping wounds too dry and slowing healing. And this really does a great job of balancing moisture, and it does promote autolytic debridement very well. We got rid of the slough and the very, very quickly, and didn't end up with a lot of fibrin on these wounds. So I think that this dressing probably would outperform most of the things in the exhibit halls in modern wound care conferences.
I should also point out that the patients really liked it. They once they'd been through a return demonstration a few times and figured out how the process worked, it was easy for them to do, and they felt empowered to take their healthcare into their own hands in most cases, and that was one of the goals. So that was very satisfying.
Yeah, they liked it better than they liked the polymem, because the polymem, you have to change the dressing depending upon the level of exudate. And this was just every day you're going to change the dressing, which is a lot simpler for them. And
Yeah.
also they liked the fact that it was sustainable, that no matter what happens, nobody's going to keep them from being able to take care of their wound. They
Right.
always have the ability to do that. It's very affordable.
That's fascinating. I mean, what a truly fascinating story from start to finish. What's the future hold for you? So you had mentioned retirement coming up, and are there more medical missions in the future? Are you trying to bring this out more into the world?
Absolutely.
What's the
But
what's the
that's
future
the
hold for the
reason
two
for
of
the
you?
retirement. Yeah.
Yeah.
So one of the
Okay.
reasons for one of the reasons for the retirement is that we know a lot of people who don't retire until their health is so bad that they can't actually do anything. And we've already done a hands-on at a large wound conference in Penang, Malaysia. We've done hands-on just showing people in Ghana. We've are upcoming at the HEAL conference in September. We're doing a hands-on there to teach people how to use it. So
And we
we
just
did
got through
just
doing
got through doing it at a medical mission seminar in Plano. So we'll be promoting this and teaching it. But the bigger goal, once again, is teaching village health workers. So we need to update our handbook. We wrote a 300-page handbook for village health
we can talk
workers.
about that.
That needs to be updated to include this wound care piece and be made international. And then we'll set up village health worker training programs worldwide that includes this.
You talked about gaps in your intro. We put together a village healthcare training book while we were working in Ghana to teach the healthcare workers, but we realized, again, looking around at what was out there for wound care, that there was just a huge gap as to what to do for wound care in those environments. So that's why this was such a big project of ours, to fill that gap and then incorporate that into an updated version of the handbook.
Yeah. Well, listen, this has been an absolutely fascinating conversation, which we sadly have to bring to an end for today. So thank you all for spending time with us today, exploring this gap, exploring this truth. We want to hear your thoughts, comments, and reactions to this conversation. So please reach out. If there are any particular topics you want to hear about or other guests you would like to see on the show, reach out and contact us. If you're listening to this on a podcast app, be sure to subscribe and leave us a 5-star review so others can find this content more easily. And if you like this particular episode, please share it with a friend. Also, don't forget to check out our website at wct-us.com for lots more educational content. And finally, be sure to tune in next time as we explore yet another aspect of the challenging and rewarding field of chronic wound care. Ciao.
And thank you.
Thank you.